Section 1. A Life Interrupted. Introducing Mrs. May. Today, we will explore the complex world of major depressive disorder. We will do this through the story of a specific individual. Let us call her Mrs. May. Mrs. May is a 33-year-old woman. She works as a marketing manager, a role that demands energy and sharp focus. She lives with her husband and their 2 young children. On the surface, her life seems full and successful. However, beneath this exterior, a difficult struggle has been taking place. Her story is one that many people around the world can relate to, a silent battle that affects every corner of a person's existence. We will follow her journey to understand this condition better. Mrs. May recently visited her primary care physician. She came with a heavy heart and a list of concerns. Her main complaints were a deep and persistent sadness, a profound lack of energy, and significant trouble with her sleep. She explained that these feelings were not new. They had been a constant presence for the last 6 months. What began as a subtle shadow has slowly grown, and now it darkens every moment of her day. The symptoms have not only persisted, but have also progressively worsened over time, making it harder and harder for her to function as she once did. This gradual decline is a hallmark of major depression. During her consultation, Mrs. May shared more details about her family history. She revealed that her mother had also battled depression. This piece of information is very important for her doctor. A family history of depression can increase a person's risk of developing the condition. It suggests a potential genetic predisposition that, when combined with life stressors, can trigger a depressive episode. Understanding this connection helps build a more complete picture of Mrs. May's situation. It is not just about her current feelings, but also about the biological context and the historical context that might be contributing to her illness. This history provides a critical clue in the diagnostic process. The timeline of Mrs. May's symptoms is crucial. 6 months is a significant period for these feelings to persist. It differentiates her experience from a temporary period of sadness or a reaction to a single stressful event. Her condition has become a chronic state of being. Initially, she might have dismissed her feelings, hoping they would pass on their own. She might have thought she was just tired, or, in a slump. However, as weeks turned into months, the weight of her symptoms became undeniable. The progressive worsening indicates that this is not a static problem, but an active illness that is tightening its grip on her life, demanding urgent attention and care. Section 2. The widening cracks. Impact and immediate concerns. The impact of Mrs. May's condition extends far beyond her internal feelings. It has created significant problems in her professional life. As a marketing manager, she needs to be creative, decisive, and engaged. Lately, she has found it nearly impossible to concentrate, make decisions at work. This cognitive slowing is a common and debilitating symptom of depression. Her performance has suffered, leading to poor reviews. She reports being absent from work quite often, unable to gather the energy to even get out of bed. The career she worked hard to build is now in jeopardy. At home, the situation is equally distressing. Mrs. May has withdrawn from her family. She was once active in family life, now isolated in her room or lying in bed. The joy she once found in her children and her relationship has faded. Her husband has noticed this dramatic shift. Her withdrawal, her increased irritability. These have strained their marriage. They now have frequent arguments about her lack of engagement. He struggles to understand. She lacks the energy or emotional capacity to explain, creating a painful distance between them. The loss of interest in activities she once loved is another significant sign. Gardening, reading. These hobbies were sources of relaxation and pleasure. Now, they feel like chores. This symptom, known as anhedonia, is a core feature of major depression. It is the inability to experience pleasure from activities that were previously enjoyable. Her garden lies untended, her books gather dust. This withdrawal from personal interests is not a choice. It is a direct result of the chemical changes happening in her brain. It shows how depression robs a person of their identity and the simple joys of life. Most importantly, there are immediate concerns about Mrs. May's safety and overall functioning. During her interview, she admitted to having recurrent thoughts of death or suicide. She has no specific plan, but the presence of these thoughts is a serious red flag requiring immediate attention and a safety plan. Her ability to function as a mother, a wife, and an employee has been severely compromised. She is aware of her symptoms and she is willing to seek help. This willingness is the first step toward recovery. Her case highlights the urgent need for comprehensive assessment and compassionate treatment. Table of Contents, Part 2, Act 1, SPAR and Assessment. Section 1. Structuring the Conversation, the SPAR Framework. Section 2. The Mental State Examination, a Deeper Look. Section 3. Assessing the Risk, Thoughts of Self-Harm. Section 4. Ruling out the Physical, Medical Evaluation. Section 5. Quantifying the Symptoms, Standardized Screening Tools. Section 1. Structuring the Conversation, the SPAR Framework. To communicate Mrs. May's case clearly and effectively, healthcare professionals use a structured tool called SPAR. This acronym stands for Situation, Background, Assessment, Recommendation. It ensures that all critical information is presented in a concise and logical manner, which is vital for making sound clinical decisions. For the situation, we identify the immediate problem. Mrs. May, a 33-year-old marketing manager, presents with a 6-month history of worsening depressive symptoms, persistent sadness, anhedonia, insomnia, and suicidal ideation without a specific plan. Her functional capacity at work and home is severely impaired, raising urgent concerns about her safety and well-being. This initial snapshot immediately establishes the gravity and immediacy of her condition for any clinician involved in her care. The background component of the SPAR provides essential context. Mrs. May lives with her husband and 2 children. Notably, there is a family history of depression. Her mother also suffered from the condition. This genetic link is a significant predisposing factor. Mrs. May has no other significant medical history and no history of substance abuse. She has been struggling to meet her responsibilities at work, with poor performance reviews and frequent absences. At home, she has become withdrawn and irritable, causing strain in her marriage. This background information creates a comprehensive picture of her life circumstances and risk factors. The assessment section synthesizes the available information into a clinical impression. Based on her presentation, Mrs. May appears to be experiencing a major depressive episode. Her mental state examination reveals a depressed mood, tearful affect, slowed speech, and slowed movements, with a preoccupation with feelings of worthlessness and guilt. Her thoughts include recurrent ideation about death. She demonstrates insight into her condition, acknowledging her symptoms and expressing a willingness to accept help. The primary diagnosis being considered is major depressive disorder, single episode, likely of moderate to severe intensity, given the significant functional impairment and suicidal thoughts. This assessment is the clinical core of the SPAR, guiding the next steps. Finally, the recommendation part outlines the proposed plan of action. The immediate priority is to ensure Mrs. May's safety. This involves creating a collaborative safety plan to manage her suicidal thoughts. A comprehensive assessment should continue, including the use of standardized rating scales like the PHQ-9. It is also recommended to conduct basic laboratory tests to rule out thyroid issues or anemia. The recommendation is to initiate a dual-pronged treatment approach, starting her on an antidepressant medication and referring her for psychotherapy, such as cognitive behavioral therapy, CBT. Major depressive disorder arises from many threads, biology, psychology, and environment, woven into Mrs. May's persistent low mood, anhedonia, and cognitive slowing. Biology, psychology, environment, low mood, anhedonia, cognitive slowing, monoamine signaling shifts, serotonin, norepinephrine, dopamine can impair reward, energy, and focus. Chronic stress dysregulates the HPA axis, elevating cortisol and disturbing sleep. Reduced neuroplasticity, dendrites sprout fewer spines, BDNF fades, then brightens. Effective treatment helps restore plasticity. Neuroinflammation, circadian disruption, and altered sleep stages. Together, they add friction and fit Mrs. May's symptoms. Step 1 is safety. Assess risk, co-create a safety plan, and provide crisis resources. Psychoeducation and lifestyle supports are foundational. Sleep hygiene activity, scheduling social connection, and limiting alcohol. First-line psychotherapies work. CBT, IPT, behavioral activation. For moderate to severe cases, combine therapy with medication. Start medication when symptoms are moderate severe, impairing function, include suicidal ideation, or when therapy alone hasn't helped. SSRIs like sertraline and escitalopram are first choice. Sertraline, escitalopram. Side effects: GI upset, headache, initial anxiety or insomnia, and sexual dysfunction. Rare hyponatremia and bleeding risk with NSAIDs. Escitalopram may prolong QT at higher doses. SNRIs, venlafaxine and duloxetine, help when pain or marked fatigue are prominent. Venlafaxine, duloxetine, nausea, sweating, dry mouth. Venlafaxine can raise blood pressure and has notable discontinuation symptoms. Duloxetine warrants caution with heavy alcohol use. Bupropion is activating, useful for low energy. Hypersomnia or SSRI-related sexual side effects. Side effects: insomnia, anxiety, dry mouth, seizure risk. Avoid in eating or seizure disorders. Mirtazapine suits insomnia, low appetite, or weight loss. Side effects: sedation, especially at low doses, increased appetite and weight gain, and dry mouth. All antidepressants carry a suicidality black box warning in young people. Close follow-up is essential. Least medication strategy: prefer monotherapy tailored to predominant symptoms and comorbidities. Sertraline or escitalopram for broad fit. Bupropion. If sexual side effects are a concern, mirtazapine for insomnia or weight loss. Optimize dose and duration before adding drugs. Trade-offs: residual symptoms may remain. Sexual dysfunction with SSRIs, hypertension or discontinuation with venlafaxine, sedation, and weight with mirtazapine, seizure risk with bupropion. Taper slowly to reduce withdrawal, especially venlafaxine or paroxetine. Monitor every 2 to 4 weeks for adherence, side effects, mood, sleep, and functioning. Expect partial response by 4 to 6 weeks. Full response can take 8 to 12 plus weeks. Reassess suicide risk each visit and provide urgent resources. If severe, urgent, or treatment-resistant, combine therapies. Consider ECT under specialist care and guidelines. Consider ketamine or esketamine in controlled infusion settings. In summary, understand the mechanisms, use stepped care, choose a tailored first-line medication, minimize polypharmacy when possible, and monitor closely, adjusting safely as Mrs. May recovers.